I'm honored to present our research study entitled Iranian Registry of Infective Endocarditis, Time to Relook at the Guideline Regarding the Regional Differences. It has been published in the International Journal of Cardiology, Heart and Vasculature in 2020. By definition, infective endocarditis is infection of the cardiac endothelium or cardiovascular devices, including permanent pacemaker, ICDs, coronary stents, and ventricular assist devices. It's an uncommon but potentially fatal disease. Infective endocarditis has high mortality and morbidity even in this modern era. The mortality is high, 25 to 30% at 1 year. In other words, 1 death in 4 patients, based on different studies, and it is not improved in the last 2 decades. I want to share you a few cases that made me think about the importance of infective endocarditis epidemiology and etiology in Iran. The first case was a 25-year-old man with history of fever, loss of appetite, and fatigue since 7 months ago, who was referred to our center for more evaluation and the possibility of infective endocarditis. He has been worked up for malignancy and chronic infection for 7 months. As you see, the aortic valve is bicuspid, and also there is a vegetation and destruction of the aortic valve. In thoracic aorta CT angiography, there is a mycotic aneurysm of thoracic aorta, which is the rare complication of infective endocarditis. Second case was a 16-year-old man who was referred for balloon coarctoplasty. He had a history of fever a month ago, partially treated with oral antibiotic therapy, and now he was asymptomatic and afebrile. The valve is bicuspid, but there was no vegetation. However, there was again a mycotic or pseudoaneurysm of the thoracic aorta just after the coarctation site. And the third case was a 36-year-old gentleman with fever since 3 weeks ago. The aortic valve was bicuspid valve with no vegetation. However, there was a thickening suggestive for abscess formation around the aortic root. And the positive blood culture with streptococcus viridans confirmed the diagnosis of infective endocarditis. Also, there was an early stage of the mitral aortic intervalvular fibrosa pseudoaneurysm. So 3 cases with bicuspid aortic valve, cardiac or extracardiac complications occurred for these 3 patients. The global burden of endocarditis is mainly unknown. Recent studies suggest that the incidence of infective endocarditis is rising in the US. There is significant diversity regarding the age, microorganism, and underlying condition between the countries. Infective endocarditis is a heterogeneous disease with so many challenges regarding the symptoms, how to diagnose, and how to manage. The clinical history of infective endocarditis is highly variable, as I showed in my cases, in the first 2 cases that I showed you. It may present as an acute, rapidly progressive infection, but also as a subacute or chronic disease with low-grade fever or non-specific symptoms that may mislead the initial assessment. So infective endocarditis should be suspected in a variety of different clinical scenarios. Patients may present to various specialists with these alternative diagnoses. They may work up for chronic infection, rheumatological disease, neurological disease, autoimmune diseases, or as malignancy. Epidemiological profile of infective endocarditis mainly has been categorized to the developing and developed countries. And they suggested in developing countries with endemic rheumatic fever, rheumatic heart disease in younger adults is a major predisposing factor for infective endocarditis. By contrast, in developed countries, there has been a shift in infective endocarditis to older patients, to more diverse infections, and more staphylococcus microorganisms. In the present study, we sought to address the epidemiological aspect of infective endocarditis, the etiology, underlying heart disease, main causative microorganisms, and prognosis in a large tertiary referral center in Iran. Between 2006 and 2018, all adult patients with possible or definite diagnosis of infective endocarditis based on the modified criteria were enrolled in the Iranian Registry of Infective Endocarditis by an expert team. This is the flowchart how we included or excluded our patients. Overall, 602 patients, more than half of them, 67% were men, with mean age of 46 years were included. Positive blood culture was 49%, less than 50%. The most causative microorganisms were Staphylococcus aureus, Enterococcus, Staphylococcus coagulans negative, and Streptococcus viridans. Interestingly, in our study, we found that the most frequent predisposing factor and underlying heart diseases were congenital heart disease, such as bicuspid aortic valve and VSDs, followed by degenerative heart valve disease, mainly mitral valve prolapse or flail mitral valve, IV drug users, prosthetic heart valves, patients with history of infective endocarditis, rheumatic heart disease, device-related infective endocarditis. Cardiac or extracardiac complications occurred in more than 50% of our patients. In-hospital mortality occurred in 18%. The mortality rate was lower in the patients who underwent surgical interventions. The IRIE is the largest case series study of patients with infective endocarditis in Middle Eastern countries. Our data indicated a high burden of infective endocarditis on community resources. Just think that more than half of our patients needed surgical interventions. They also need prolonged hospitalization. They need for extensive antibiotic therapy and intensive care. These days, despite diagnostic and therapeutic advances, still infective endocarditis has a high mortality and morbidity. Also, we found that infective endocarditis occurs at a younger age, almost in 46 years old, when the individuals are expected to be at the peak physical activity compared to the older age that has been suggested in the systematic review for infective endocarditis. They mentioned 57. Our data was very close to the data that they studied regarding the infective endocarditis in Turkey. The mean age of the patients were also 47, very close to our data. I just want to briefly talk about the recent study, another interesting study regarding the epidemiologic data in the countries around the Mediterranean Sea. They reported remarkable differences regarding the patient's age, causative microorganisms, and underlying heart disease between these countries. As you see, the northern countries, the age of the patients with infective endocarditis are more than 60 years old. And in the southern countries, the age of the patients are less than 40. Also, the negative blood culture ratio is higher in the southern countries, the blue one, and much less in the northern countries. In southern countries, patients were younger, less than 40 years old. Rheumatic heart disease and Streptococcus viridans were the main risk factor for infective endocarditis, and blood culture negative endocarditis was highly prevalent. In northern countries, patients were older. Rheumatic heart disease was not a major risk factor. There was a high rate of prosthetic valve or cardiac electronic implanted devices. And the main microorganisms was Staphylococcus aureus. Eastern Mediterranean countries had something intermediate or between these two countries, at an intermediate situation. regarding the age, etiology, and also the microorganism. Also, I want to emphasize the role of endocarditis team. Infective endocarditis is not a single disease. It has different manifestations regarding the underlying heart disease, the microorganisms, the complications that can become cardiac or extracardiac. Very high level of expertise is needed for management of these patients. And several specialties have to be involved, including cardiologists, cardiac surgeon, infectious disease specialist, microbiologist, neurologists, neurosurgeons, and experts in congenital heart disease, and etc. Presence of endocarditis team with multidisciplinary approach has already shown to be useful in the hospital course. Also, in our establishment of IRIE, we had the multidisciplinary team approach, and we showed that we had more positive blood cultures after multidisciplinary team approach, more guideline-based antibiotic therapy, and significantly less cardiac and extracardiac complications when we approach our patients with endocarditis team. These two groups, bicuspid aortic valves and degenerative mitral valve diseases, including MVP, prolapse mitral valve prolapse, or flail mitral valve, can be considered as high-risk group for infective endocarditis. Our findings were contrary to the previously reported data that they mentioned. In developing countries, rheumatic heart disease is the main cause of infective endocarditis. There was another study in Spain. They found that there is a changing in epidemiology and dominance of the bicuspid aortic valve and MVP as a common cause of infective endocarditis, very similar and consistent with our study and data. They categorized bicuspid aortic valves and MVP as high-risk conditions for infective endocarditis. They also found higher streptococcal virulence in their patients with bicuspid aortic valve and MVP. That's why they recommended infective endocarditis antibiotic prophylaxis for these two high-risk groups, which is not in the guideline yet. In conclusion, infective endocarditis is a fatal disease involving multiple organs, resulting in high morbidity, mortality, and high socioeconomic consequences, despite significant improvements in diagnosis, medical, and surgical therapeutic strategies. There is a significant diversity regarding the underlying condition, age, and microorganisms between regions and countries. And more importantly, there is a lack of epidemiologic data in many developing countries, which is crucial for proper diagnosis, optimal management, and prevention for these patients regarding their morbidity and mortality and this negative impact of socioeconomic consequences that infective endocarditis have on the people. Thank you.